Good day to everyone. This is my talk on the current gaps in telehealth and how to address them. This is Dr. Alvin Marcelo. Some disclosures. My outline will follow this. What is telehealth? Why is telehealth relevant now? A simple framework to remember the different components of a telehealth consultation, the ABCs, and some challenges that we face right now with Philippine telehealth and how we may address them. So for the complete guidance on telemedicine, you may go to bit.ly/UPMIU Telemed 2020, and we have several documents there created by the Masters of Science in Health Informatics faculty and students. So what is telehealth? According to the World Health Organization, it is the delivery of healthcare services where patients and providers are separated by distance. It uses ICT for the exchange of information, for the diagnosis and treatment of diseases and injuries, research and evaluation, and for the continuing education of health professionals. Telehealth can contribute to achieving universal health coverage by improving access for patients to quality, cost-effective health services wherever they may be. It is particularly valuable for those in remote areas, vulnerable groups, and aging populations. And recently, because of the pandemic, there has been increased awareness and demand for telehealth. Even if the field by itself was already in practice more than 30, 40 years ago, it was the pandemic that brought out the value of telehealth. And so, right after the announcement of the WHO of the pandemic, several publications were released regarding the topic. This one from the CDC, this one from the BMC, from the government Ministry of Health of the US, several other publications from long-standing telemedicine researchers like Dr. Dorn, the American Academy of Family Physicians, the Lancet, and finally, the Department of Health, April 7, 2020, released preliminary guidelines on the framework for telemedicine services. And this was used by several organizations to help set up their telemedicine capabilities. So if you look at a typical telemedicine consultation and you break it up into its most elemental components, essentially it is really an interaction between two people. One is the sender and one is the receiver, and they exchange messages with each other. So technically speaking, a conversation is a telehealth consultation, and a telehealth consultation is a conversation. And simple as it may look like, that there might be at least 3 components in a telehealth consultation. As a matter of fact, it's more complex than that, because there's the element of the ability to express clearly what you're thinking and what you wish to put into a message, and the best effort that you put in expressing your message. And on the other hand, the ability to comprehend of the receiver and their sincerity to understand and believe everything that you have sent them through your message. And then back and forth, between the doctor and the patient, there will be messages going back and forth. And these are things that we take for granted in a face-to-face medical setting. But in a telehealth setting, it becomes very challenging for several reasons that I will present later on. Another way to look at telehealth would be a time-based perspective where you have a set of activities that you do before the teleconsultation process, during the teleconsultation proper, and then after the teleconsultation session. And so I created this very simple framework. It's not comprehensive, but to me, I think it's simple enough for us to remember and for practitioners to mind so that they don't miss out on the major components of a telemedicine or a telehealth consultation. So I called it the ABCs because it follows the A and the B's and the C's, the actors, the agreement, the bridge, connectivity, content, and continuity of care. So let's go through them one by one. If you imagine a telemedicine consultation as a box, and there would be stakeholders inside that box, then it would be the patient and the doctor. And you can imagine that box as a secure and a private box, and that's the sacredness of the encounter between a doctor and his or her patient. But in a real setting, even in a face-to-face setting, and much more so in a telehealth consultation, there might be other people, especially caregivers of the patient, who would assist them into your clinic or would assist them through the technology to get them online, especially for the elderly patients. And on the side of the doctor, you might also have other health professionals, the nurse, the receptionist, or other medical technologists that the doctor might need to support the patient during the telehealth consultation. And then there's this special person called the coordinator who need not necessarily be a health worker or a healthcare professional, but she or he is the one who tries to make sure that the encounter of the patient and the doctor is smooth, has all the minimum elements needed to make it safe and secure, and that it happens. And we often take this for granted. The coordinator often works at the background, but without the coordinator, then the doctor by himself or herself might not be able to conduct a smooth, seamless telehealth consultation. A is also for agreement, and this is simply just the consent that you need to take when you're doing a telehealth consultation. Again, in a face-to-face setting, we take this for granted, but the Data Privacy Act of 2012 actually says that we should be taking consent even in our ambulatory face-to-face setup. So don't forget to take your consent, especially for your telehealth consultation. B is for bridge, and I assign this term to the technology platform that will be used by the actors, the doctors and the patients, the caregivers and the other health professionals. And here you may choose to do video conferencing, SMS, instant messaging, electronic mail, or even just by voice over a plain old telephone system. Okay. And C is for connectivity, and it might seem like a repetition of bridge, but here I would then summarize this as real time, whether it's voice or video, and store and forward, like electronic mail, SMS, and in quotation marks, instant messaging, because instant messaging is almost like real time, but it's not really real time. C is also for content, and this is basically everything that happens after you obtain your consent and then you start the telehealth consultation proper. And this is basically the meat of the consultation, where you talk to the patient, get the history, try to do the best physical examination that you can, despite the limitation of the remoteness of the patient, where you try to come up with an assessment, a diagnosis, and then you come up with a plan of action for your patient, treatments or laboratory tests, and then you educate the patient and try to set up a follow-up. C is also for continuity of care. And this has become very important, especially during the pandemic, when the patients would come in and out of your care, would go to other health professionals, might be receiving medications from other health professionals that might have drug-to-drug interactions with the medications that you prescribed in your teleconsultation. So this has become more important in the pandemic, but it's already been a problem even before the pandemic, when patients would go to different doctors and would get different prescriptions, and then they would take them all together and not get well. And the reason is Dr. A's drug counteracts the beneficial effects of the medicines prescribed by Dr. B. And because we don't have transparency on what are the active medications of the patient, unless they are transparent enough to tell you that these are the medications I'm taking from all the other doctors, then these challenges of drug-to-drug interaction will always happen. So I think, looking at it from the systemic perspective, the continuity of care record is an important component of a telehealth consultation. And we'll talk more about this later on when we get to the challenges. So how do we address the challenges that have appeared as we employed telehealth during the pandemic? So again, let's approach the challenges based on the ABCs. So let's look at the actors. The first actor, like the doctors. Many of the senior doctors were caught unawares about the needs for a telemedicine consultation. So they lack the knowledge on how to use a technology, how to use electronic mail, how to set up a calendar appointment, how to send an invitation, how to start a video conferencing teleconsultation, how to appear and how to project themselves into a computer screen in a way that will bring confidence to the patient that they're actually undergoing a proper consultation process. On the other hand, for the young people who are very familiar with the technology, they might not have enough clinical experience to actually guess or see what's not visible immediately to the inexperienced eye. So we have senior clinicians who can, diagnose a patient right after they enter the door of their clinic, and they can have that experience in a telehealth consultation. But the younger doctors might not have enough of that experience to have that clinical eye to see what the patient might be suffering from just by looking at them right after entering the door of the clinic, or right in the first few seconds of a video conferencing session. And then the confidence, it hits both the young and the old. Again, for the same reasons that when there are new things that enter our workflow, it takes some time before we gain confidence in using these new tools and technologies, or looking at these new cases and understanding what they mean. And the lack of confidence can sometimes be felt by our patients. And so the solution to this is very simple, and we've been doing this for the longest time in medicine. It's basically practice, capacity building, learning how to use the tool properly, safely, making sure that the people who know are beside the people who are learning, so that as the people who are learning, the students are gaining confidence, they have their mentors beside them, advising them and monitoring that they're doing it the right way, and then giving them feedback on how to improve for the next session. These are things that we take for granted in a face-to-face setup, but we have to be more explicit and deliberate when we go to a telehealth type of capacity building. On the patient side, again, this is very, very challenging because for the younger patients, we might not have some problems with them accessing the technology. For the older patients, they will need the support of their children or grandchildren to get them online. But the real problem with patients, and this is not their fault, but the challenge of doing telehealth consultations is how to identify properly your patients in a purely telehealth setup. So let's go back to our face-to-face setup. When the patient goes to our clinic, they usually fill up a bio form where they put their name, their birth date, their sex, their address, and they give this willingly because you want to register them, and that's what we call it. We register the patient into our system, whether it's a paper-based system or an electronic medical record. That's the first thing we do. We register the patient by collecting their private information, personal information. This personal information is the foundation of our clinical documentation, because everything that we do, the history, the physical examination, will have to be attached to that personal information. The treatment, the procedures, even the complications are attached to this identifier of the patient. And it's a safety issue. It's a safety factor, because if we are unable to identify the patient properly, then we might be assigning your clinical documentation to another patient. And if you don't have very good record keeping on the identity of your patients, your records and your documentation can get mixed up, and it can result to disastrous effects to our patients. So another challenge with our patients are their reluctance to use the technology because they're more familiar with the face-to-face setup. Of course, the pandemic and the lockdowns essentially force them to accept telehealth technology. So this reluctance is still there, but is decreasing. Comprehension will always be a problem. It's been a problem in face-to-face setups and continues to be a problem with telehealth systems. You just need to exert more effort making sure that they understand your instructions. And we have techniques to do that. You give them instructions, you ask them to repeat it to you, and you confirm that their awareness and understanding are correct. So the solutions to this, there are standards already in identification. You ask them for their name, you ask them to confirm their birthdays or the address or any other parameter. So at least 2 parameters to confirm their identity is very important. And then it's important also to assure your patients that these telehealth sessions are safe and that you are always there for them and that they can always ask questions if they have any. On the relatives and the caregivers, some of them might not actually be able to adequately represent the patient. They may be misrepresenting the feelings or the symptoms of the patient. They might not understand the full history, but are forced to express whatever history they know from their perspective. So this can be a challenge. And this is also a challenge even in face-to-face settings. They don't have, unless they are healthcare workers themselves, they don't have experience with physical examination. So they might not be able to describe hard from soft, from doughy. There's also the risk of a privacy breach, that the patient and the doctor might have the contract, that there would be privacy between the confidentiality between the two of them, but the relatives and caregivers might not be that committed to that confidentiality. So some partial solutions to this problem is to ask the patients to disclose who are these caregivers and relatives around them during the telehealth consultation, and to tell them the nature, tell you the nature of the relationship, for them as patients to explicitly give consent that these relatives and caregivers will be participating, and for you to also educate these relatives and caregivers on their compliance to the conditions of the consent, even if the consent is just between the doctor and the patient. Most particular here would be the no recording. If it is your policy that no recording should be done of the telehealth consultation, then that is something that you might wish to explicitly tell them. For other health professionals, the lack of training and the lack of tools limits the potential of the telehealth consultation. Again, capacity building and the integration of telehealth in health professions education will solve this. For the coordinators, they can err in identifying the patient and therefore telling you that you have an appointment with Jose Rizal, but type Jose Reyes in the calendar invitation, and that creates some problems with your clinical documentation later on, especially if this patient is new and you don't know Jose Rizal from Jose Reyes. It can cause some problems with matching patient and doctor. I've seen some coordinators that have set up patients looking for eye doctors to ENT doctors, so that can be a problem. And of course, the problem of confidentiality and breach of privacy are always there, and the solution is capacity building and training. For the agreements, most doctors do not obtain signed informed consent, and this is really a challenge. And if you look at the Data Privacy Act of 2012, the requirement is that the consent should be recorded. So I think we should be innovative here and look for ways where we can get this consent recorded. And it doesn't necessarily need to be a signed informed consent. It just needs to be recorded. So I won't go into the different ways you can get a recorded consent, but definitely using consent templates work very well. And if you can find a way to embed this consent taking into your workflow, then that would be very helpful. So here are some sample consents at the bottom. Now for the bridge, whether you're using SMS, electronic mail, instant messaging, voice, or video conferencing, some of the challenges would be what we call signal to noise ratio, where because of the irregularity of the messages, for example, in SMS and email, and the crisscrossing of messages between sender and receiver, then there are potential for misinterpretations of some instructions and messages, because if you don't have a real-time way of communicating, then you could get into some misunderstanding of what the other person was trying to say, just because of the asynchronous type of exchange of the messages in SMS and electronic mail. Now, some solutions here are tools that are already available, like digital stethoscopes, digital ophthalmoscopes, otoscopes, electrocardiograms, sphygmomanometers. So there are tools already that are available, and I think we should use some of them. The challenge really here is that these tools are on the remote side, on the patient side, and if the patient or the caregiver are not familiar with how to use the tools, then they're basically useless. So I think this is a solution that has not completely solved the problem, but it's part of getting into that final workable solution that our patients will need. For connectivity, this is a problem in the Philippines. We have very slow internet in some areas of the country. There isn't a cellular signal, and the quality of the communication between the two actors is actually limited by whatever is available. So if it's just SMS, then that's the technology that you will be able to use, because that's the only thing available for you. And I think the solution here is where this is where government comes in and incentivize the private sector to start putting up infrastructure so that we can have at least the minimum levels of connectivity that we need for safe telehealth uh, consultations. For content, telehealth sessions will never match the quality and the detail that we would get in a face-to-face consultation. And this is obvious because in a telehealth consultation, we cannot touch the patient. We can in a limited way inspect the patient, but we cannot palpate, we cannot percuss, we cannot auscultate without the right tools. So the inability to perform the complete physical examination limits the degree and the sophistication of the content that we can do in a telehealth consultation. So therefore, we have to add risk awareness in our capacity building to inform the practitioner and the patient that, you know, this session is not the ideal setting, but we should make the most out of what we have. We will use digital tools where they are appropriate, where the tool operator is informed and educated how to use the tool properly. Again, integrate telehealth in the health professions education. And I'm encouraging professional societies to create telehealth checklists to guide their members so that these checklists can be followed by their members, and by doing so, they're making sure that they're covering the important aspects of a telehealth consultation, for example, in pulmonology or nephrology and the like. Continuity of care is a challenge because the practice that we have right now in the Philippines is not continuous. So we operate in a fragmented type of a healthcare system. The bigger chunk of separation is the private sector and the public sector. Even in the private sector, there are fragmentation between different groups. And despite the abundance of the digital solutions like tools, electronic medical record software, and connectivity, the practice by itself is fragmented. So I don't think we will have the solution overnight. Okay? Even the patient data are in silos, and doctors have no visibility on the patient's full record. So here, I don't think telehealth will be the complete solution. We need to have electronic medical records. We need to have policies by government to share data where it's necessary to share data. And so here, the solutions on top of telehealth would be electronic medical records, policy to share clinical abstracts, and discharge summaries. But possibly the greatest challenge in telehealth is how to accept new patients the first time using the technology, where you have not had an initial face-to-face meeting and therefore you have not been able to do a complete history and physical examination of your patient. Again, the problem of identifying the patient properly and performing the complete physical examination. And for this challenge, the consent is very important because in the consent you have to identify the patient and he commits to his identity and his honesty. You can also use identity services. There are emerging identity services online where they sign up to these identity services, and these identity services vet who these patients are. You can also limit your patient base to those that were referred to you by a known colleague. So this is like creating a web of trust. so that you don't take strangers. This is somebody that was already seen by somebody you know, and that other colleague will then vet the identity of this patient for you. A challenge, definitely, but there are solutions and there are ways to mitigate this risk. So, summary number one, the ABCs help us remember the people, the processes, and the technologies involved in telehealth. Most challenges and shortcomings exist, even with face-to-face interactions, but they get amplified with telehealth. Telehealth introduces more risks compared to face-to-face. Telehealth practitioners should be aware of these risks and should ensure that patients receive their benefits without being harmed. The country is missing out on the opportunity for universal health coverage through appropriate use of telehealth. We should keep monitoring DOH and PhilHealth telehealth policies to ensure that you are using the right technologies. And that ends my lecture. Thank you very much.